everybody, and today we are starting our lecture series with clinical nutrition, and we're going to talk a lot about the basics. So in today's basic lecture, we're focusing on metabolism. So when you have a moment, take a look at the objectives. All right, let's start with intake, digestion, absorption, and excretion. So first of all, let's recap some gut hormones. If you remember GLP-1, glucagon-like peptide, that's an important hormone for you to remember. It is involved in decreasing appetite, decreasing glucose production, and increasing insulin production. So its net overall effect is to make you less hungry, reduce your blood sugar, and increase your insulin. The bad thing about GLP-1, which by the way is secreted by the cells of your intestines, is that it is rapidly degraded. After it's released, it's gone in about 2 minutes. It's degraded by DPP-4, which is dipeptidyl peptidase, an enzyme that degrades GLP. So its effects are not very long-lived. Leptin, another gut hormone that you should remember, is actually produced by adipose cells. So the more adipose cells you have, the more leptin you produce. So it would be fair to assume that somebody who is overweight or obese actually has more leptin levels. So then if you read the slide, you're thinking, well, high levels of leptin should actually reduce appetite. So why is it that in individuals who are overweight or obese, their appetite is not reduced? So it's been found that actually there's a resistance to leptin that occurs in these individuals, similar to insulin resistance. Our third hormone is called ghrelin. That's known as the hunger hormone, and I'm sure you've all experienced this. When the stomach is stretched and full, we do not secrete this hormone, and it is not absorbed. When the stomach is empty, this hormone is secreted and it's absorbed into the bloodstream, and it affects the brain and makes you hungry, or what I like to call hangry. So we've all experienced this. So remember, high levels of ghrelin, you're hungry. High levels of leptin, your appetite is actually reduced. Okay, let's see how much of what I just told you remember. So can you name these musical artists who were hangry like the wolf? And do you remember that hangry hormone that I just mentioned?
In touch with the ground, I'm on the hunt, I'm after you. Smell like a sound, I'm lost in a crowd, and I'm hungry like the wolf. Straddle the line.
Hopefully you remember Duran Duran, and more importantly, ghrelin, the hangry hormone when it's high. All right, so let's continue back to GLP-1. Remember, glucagon-like peptide. As you can see, it's secreted by the cells of the intestine, but it affects almost every organ system. The important thing to remember here is that the net effect of increased levels of this hormone are reduced blood glucose, increased blood insulin, decreased appetite, decreased gastric emptying. So it's no surprise that GLP-1 is a hormone that's targeted by many medications in the treatment of diabetes. So a little medication refresher for everybody, GLP-1 agonists. So remember, if we agonize GLP-1, we're going to reduce blood sugar, reduce appetite, increase insulin stimulation. So always remember the generic names of your medications. Number one, they're easier to remember because as you can see here, all these GLP-1 agonists end with Tide. So it's much easier than trying to remember their brand names, which are completely different. You also won't make medication errors when there's combination medication. So always remember your generics. So GLP-1 agonists are given to patients with type 2 diabetes to reduce their blood sugar. Now, remember, we also said GLP-1 in the bloodstream degrades really quickly. So, very smartly, DPP-4 antagonist. So we antagonize the enzyme that breaks down GLP-1. And these medications shown below, again, remember their generic names. As you can see, the endings are all gliptin, will help reduce degradation of GLP-1. So if we agonize GLP-1 and we antagonize DPP-4, we help reduce blood glucose. And this is some of the things that are used in the treatment of type 2 diabetes. Okay, moving on. This diagram just helps reiterate what I just explained as far as the actions of GLP-1 and DPP-4 and where the drugs are meant to target this hormone and enzyme. Okay, the process of digestion. So let's start with your mouth. Obviously, you have mechanical digestion. So as you chew, your mouth helps break down food. At the same time, don't forget your parotid gland secretes saliva, and that saliva contains amylase. So amylase is an enzyme that breaks down carbohydrates. Your saliva is also alkaline to help stimulate and activate this amylase so that it can aid in the digestion of carbohydrates. So digestion actually starts in your mouth. Your esophagus helps out by helping move the food down your esophagus and with peristalsis into your stomach. In your stomach, you have several things happening. Acid helps break down food. Pepsin helps break down protein. And then the mechanical turning of your stomach helps further aids with mechanical digestion. All of this food and digested material turns into a slurry referred to as chyme. And then the chyme passes through the pylorus into the duodenum. Now remember, in the duodenum, you have pancreatic enzymes coming in. In addition to pancreatic enzymes, you have bile entering. We're going to talk about that in a little bit more detail later. Once down into the small intestine, now these digested elements of food are able to be absorbed. Almost 100% of that occurs in the small intestine, leaving the large intestine to aid with absorption of mostly water, vitamins, and minerals. And this diagram helps you see what points along the way different items are actually absorbed and in what portions of the digestive tract. Okay, one other thing that we want to talk about while we're in the lumen of the intestine is this really neat transport protein called SGLT1. So that's easy to remember because the S stands for sodium, G stands for glucose, linked transport protein. Easy name. So this protein helps move glucose and sodium together against the concentration gradient. And you guys can see here, there's a higher concentration of glucose in the bloodstream versus the amount of molecules that are in the small intestine. So it's usually difficult for these to move against a concentration gradient. However, with this transport protein, they're able to do that. Why is that important? You'll notice many sports drinks mix sodium and glucose together. And because of that, they're able to move against the concentration gradient and better hydrate you. So when you're trying to hydrate your patients, you don't want to offer them sugar-free beverages. You want glucose and sodium to aid in that absorption. So it's important to remember that this is SGLT1 as we move on to another medication refresher. SGLT2, however, is found in the proximal tubule of the kidney. It's the same thing, sodium glucose linked transport protein. It does the same thing. It moves sodium and glucose against the concentration gradient back into the bloodstream. So why would we want to block that in the proximal tubule? Another diabetes medication. So if we can block the reabsorption of glucose back into the bloodstream, we're going to decrease glucose, right? So that seems like a pretty good idea, but there's a lot of side effects with this medication. So as you can imagine, if blood glucose is not getting reabsorbed back into your bloodstream and instead it's spilling into your urine, what happens? Well, for one thing, obviously you're at risk for hypoglycemia and ketoacidosis, but more importantly, you're at increased risk for microbial infection, right? Because basically now you have sugar in your urine that is a great environment for the growth of different microbes. And in fact, Fournier's gangrene has been shown to be increased in individuals who are on this medication. Okay, so one last note on our GLP-1 agonist. If anybody remembers the monster that led to the development of one of the first GLP-1 agonist medications, the Gila monster, a venomous lizard that's common to us over here on the West Coast, mostly Arizona. It was found that the saliva of this animal has exendin-4, which is 50% identical to human GLP-1. And furthermore, it doesn't break down as quickly as human GLP-1. So the saliva of the Gila monster was used to develop this initial drug. Interesting little fact. Okay, moving on to acid-related pathophysiology. So when we're talking about the stomach, like I mentioned, you have HCl, bicarbonate, pepsinogen, which is later activated into pepsin, then intrinsic factor, mucus, and prostaglandins, which I have not yet mentioned. Intrinsic factor is secreted by parietal cells in the stomach. It binds to vitamin B12 and allows it to be later absorbed in the ileum. Mucus is secreted by mucus cells, and then prostaglandins, which are secreted by the gastric mucosa, which I'll talk about on this next upcoming slide, aid in peristalsis, increase mucus production, and decrease gastric acid secretion. Why is this important to know? When we give our patients medications that block prostaglandins and are non-select, so that means it's blocking prostaglandins across the board, including these ones in your gut, you increase your patient's risk of peptic ulcer disease. So what would be a prostaglandin inhibitor that does this? Ibuprofen and Aleve. All right, let's move on to cells of the gastric gland. Parietal cells, I've mentioned those. These cells produce and secrete acid, and not surprisingly, they are the main site of action for many medications. And I'll show you in the next slide how that's illustrated. Remember, these cells also secrete intrinsic factor, which binds to B12. Chief cells secrete pepsin. Mucus cells, easy to remember, secrete mucus. And then enterochromaffin-like cells, ECL cells. It's important to distinguish those between enterochromaffin cells. So EC cells secrete serotonin. ECL cells secrete histamine. Histamine is a potent stimulator of parietal cell secretion of acid. So here you can see the parietal cell. And you can notice that there's many receptors on the parietal cell. Anytime these receptors are stimulated, it prompts the parietal cell to turn on its proton pump and release acid into the stomach. So this can be stimulated by acetylcholine, by histamine, by gastrin, coffee, alcohol, many other things. And as you can see, these are the sites of action for drugs to block this acid secretion. So we have anticholinergic agents, antihistamine blockers, or histamine blockers that prevent this stimulation of the parietal cells. Ultimately, though, proton pump inhibitors, which are the most effective, actually block this proton pump and cause the cell to need to regenerate and whole entire new pump. Okay, so an easy way to remember that your chief cells secrete pepsin. You can remember the peppy chief or the peppy police chief secretes pepsinogen, which becomes activated in the stomach to pepsin and breaks down proteins. Mucus cells is easy. Why does your stomach secrete mucus? It doesn't really aid in digestion per se, but it does protect your stomach from digestive juices and acid by coating the surface of the epithelial cells. So as I mentioned, hydrochloric acid can be stimulated from those parietal cells with various factors. It helps maintain an acid environment, but acid is our friend. It's not bad. Yes, it can lead to destruction of tissue, but generally it does not because we have protective factors like prostaglandins and mucus. The great thing about acid is it aids in digestion and it defends us against microbes. So long-term acid suppression with proton pump inhibitors can oftentimes make us more susceptible to GI infections, even pulmonary infections. It decreases actually absorption of vitamin B12, calcium, and other vitamins and minerals, and can put our patients at risk for different types of anemias and fractures. And one last thing I would like to mention is you can even stimulate those parietal cells to secrete acid because of psychological stress. So by blocking histamine or blocking the cholinergic receptors, you are not necessarily stopping the acid secretion. Even stress can stimulate the cells. And here's just another little illustration. So you see here, we have these ECL cells, remember enterochromaffin-like cells, which release histamine, which comes to the parietal cell, stimulates it to then release acid into the lumen of the stomach. Okay, let's see if you can remember what I just discussed. What is the name of the cell that can release intrinsic factor and HCl? Hopefully you've already answered with parietal cell. What is the vitamin that can become deficient because of damage to parietal cells? And you've hopefully quickly responded with B12. What type of anemia can result from this damage? Now, this is going back to your medicine courses, and hopefully you've responded with pernicious anemia. And one last thing I want to reiterate is, as you become clinicians, always become involved in looking at your patient's lab values yourself. So if you think your patient has anemia, prepare or have lab prepare a peripheral smear for you. So when you get a peripheral smear, it can look something like this. And in this case, if you've gotten used to looking at these, you're going to right away recognize two major problems. You're going to look at these red blood cells and you're going to say, these are big or macrocytic. And then you're going to look at this cell, and first of all, you're going to identify it as a neutrophil. And then second, you're going to notice that it's hypersegmented. So there's too many of these lobes. So anytime you have 6 or more lobes, you can consider your neutrophil to be hypersegmented. That's pathognomonic for B12 deficiency. Okay, so back in the duodenum, we also have bile. Bile is made by the liver, stored in the gallbladder, and then excreted into the duodenum. It's almost 100% water. It's 97% water. But it's also made up of some other ingredients, importantly, lecithin. So bile acts as an emulsifying agent and allows fat that you've consumed to be emulsified and to be absorbed into the bloodstream. In fact, without bile, almost 50% of the fat that you eat will not be absorbed. With bile, almost 100% of it is absorbed. And you can think of bile as the Dawn dish soap of your body. So, you know, the commercials where you have the ducks and they're all oily, you put the Dawn dish soap and it emulsifies the fat and lets it wash off. Similarly, in the gut, it breaks up the fat into tiny little molecules and allows it to be absorbed into the lymphatic system. Okay, and then the pancreas. So we all think of the pancreas, we think of, okay, it produces and secretes insulin, and that's its endocrine function. But don't forget, it has very important exocrine functions as well. So the acinar cells of the pancreas produce multiple enzymes, amylase, lipase, and trypsin. They're produced as zymogens or inactive proenzyme forms so that they do not digest the pancreas itself. This happens sometimes in pancreatic injury leading to pancreatitis, but they're not supposed to become activated until they hit the alkaline environment of the duodenum. So amylase, one of those enzymes, breaks down carbohydrates. We also test the blood or the serum for amylase to check to see if there's pancreatic injury. However, amylase is not specific to the pancreas. As you can see, it is also found in female reproductive organs. It's found also in the parotid gland. It's also found in the duodenum. So injury to any of these areas, excessive vomiting even, can increase amylase levels. Lipase, on the other hand, is specific to the pancreas. Lipase breaks down fat, and when you see elevated levels in the bloodstream, you can assume that there's been pancreatic injury. And then back to endocrine function of the pancreas. When you check the blood sugar or blood glucose levels, that determines whether or not you have functioning cells of the pancreas that are involved in secretion of insulin and glucagon. So if we take a look at the pancreas here, you can see these neat little acinar cells that line all these little tiny ducts that eventually all form and come to the main pancreatic duct. They are making all these enzymes, amylase, lipase, and trypsin, in these proenzyme inactivated forms, and they're secreting them here, ultimately going into the duodenum, where they become activated. The endocrine function of the pancreas here, so within the islets of Langerhans, you have the alpha cells, beta cells, and delta cells. These will secrete different hormones that ultimately make it into the bloodstream. So exocrine function, going into the duodenum. Endocrine function, hormones are going into the bloodstream. Your alpha cells secrete glucagon. Your beta cells secrete insulin, and your delta cells secrete somatostatin. And that concludes our lecture.